transition. Our fourth panel is Advancing Precision Mental Health, Integrating Neuroimaging, AI, and Therapeutic Innovations. This session will delve into the cutting-edge tools and treatments that are reshaping our ability to diagnose and care for patients. I'm delighted to introduce the chair for our next panel, Dr. Carolyn Rodriguez, who will guide us through this session and also introduce the panel speakers. Dr. Rodriguez is the Associate Dean for Academic Affairs at the Stanford School of Medicine and is Professor of Psychiatry and Behavioral Sciences. She directs the Stanford OCD Research Lab and leads translational, clinical, and mechanistic studies of rapid-acting treatments for OCD and other mental health conditions, including pharmacotherapies, non-invasive brain stimulation, psychotherapy, and suicide prevention interventions. Please join me in giving a warm welcome to Dr. Rodriguez.
Okay, you guys are in for a real treat in this next section. It is my pleasure to introduce your first speaker, Dr. Teddy Akiki. He is a clinical assistant professor in the Department of Psychiatry here at Stanford and associate director of computational neuroscience and AI-driven clinical translation at the Stanford Center for Precision Mental Health. He's a physician scientist, and his translational research integrates artificial intelligence, multimodal neuroimaging, and clinical neuroscience to advance precision psychiatry for a number of disorders. His work focuses on developing computational tools to map stress-related neural circuits, building AI-based neurobehavioral foundational models for treatment prediction and stratification, and conducting neuroimaging augmented clinical trials to validate predictions and refine therapeutic strategies. As a board-certified psychiatrist, Dr. Akiki treats patients in the Stanford Translational Precision Mental Health Clinic, incorporating these emerging research advances into our clinical practice. So join me in welcoming Dr. Akiki.
Thanks so much, Carolyn. It's great to have this opportunity to speak to you all, and I look forward to the discussion session. But until then, I want to talk to you about our work on developing AI foundation models, specifically designed for neuroimaging data, with the ultimate goal of making pragmatic and useful predictions when it comes to psychiatric questions. In psychiatry, we still lean heavily on trial and error. Two different people with vastly different brain biology, vastly different symptom profiles may still get the same diagnostic label. That's often the case. And the way we approach treatment is generally based on that label and some guidelines. We take a best guess at what should be the treatment. We have no objective way of knowing beforehand whether someone's going to respond or not. So naturally, there's a lot of trial and error. It takes several cycles. As you heard from the previous speakers, it takes several cycles for someone to find a medication that works for them, if any. And I believe that we could really do better. And so the main question that's driving the work that I'm going to present today is whether we can find a robust computational tool that can help guide us in a data-driven fashion and help us refine our probability estimates for when we're trying to estimate whether someone's going to respond to a specific therapy or not. The reason why I chose to focus on the brain as the main organ where to find this signal, let's say, as opposed to a blood-based biomarker, is because, like many people in this room, I believe that the brain is the most proximal organ to psychological distress. And so I placed my bet on the brain because my assessment was if there's going to be a signal, that's where it'll likely be found first. Not that it cannot be found elsewhere, but I think we stand to find the best chance we stand is by looking at the brain directly. Now, one of the challenges is unlike neurological disorders like multiple sclerosis, where with the naked eye you could look at the brain scan and find a lesion. Pathology in psychiatry is very subtle. We think it occurs at like the microcircuitry level generally for most disorders. And so you cannot see it with the naked eye, very hard to see on structural scan. And so that's why we decided to look at function, brain function with functional MRI, which gives us a tracing for a proxy for brain metabolic activity from every region of the brain. And then we could look at how that is different in individuals with mental health difficulties. Now, another challenge that people in neuroimaging face is that generally, when you recruit people for studies, it generally goes by label. You're recruiting a cohort with MDD. And so those labels, they create a lot of heterogeneity because as I mentioned, you could have different people in the same buckets. So one solution that we found was instead of thinking of a disorder as the statistical unit, whereby you're looking at a whole sample, you could flip this and then consider the individual patient as the statistical unit. Another barrier is signal complexity. There's the brain signal is very complex, a lot going on there, high dimensional. It also has a lot of noise. And what we've been able to do over the years as a field is refine our methods and find methods that are more robust to noise and complex enough to capture those complex interactions. And finally, we have in neuroimaging, the data sets are very small by AI standards. So typically a couple of hundreds patients per data set, as opposed to the tens of thousands or hundreds of thousands that you need for typical AI applications. So thankfully, one paradigm that recently, that you just heard about actually, the foundation model paradigm, can be applied in this case. So by the definition of a foundation model, which was actually coined here at Stanford, is a model that's trained on broad data that can be adapted to a wide range of downstream tasks. Complicated definition. I don't even know what that means specifically, but I'll give you a good analogy. As a recent parent, what I realized was that the foundation model paradigm is very similar to raising a child. What I like to call it is let chaos learn and then write the fridge rules. Essentially, free-range child mode is a toddler experimenting around the house, falling, dropping food on the floor, discovers gravity this way. And then after that foundation, then you could intervene and post what the fridge rules are. This household, no dropping cups on the floor. Way more effective, trust me. So you've seen this at work, this paradigm at work, as previous speakers perfectly illustrated. So just to recap quickly, like a simplified version of what's going on here is there's you can think of it as being a two-step process. First step, unsupervised. You just let it do its own thing. You get a base model, which then you could fine-tune in case of large language models, let's say with question-answer pairs. That's overly simplistic, doesn't account for many of the more sophisticated things, but we could distill it to this essence. So what we set out to do was do something very similar, but for brain imaging. So essentially, our thought was, we could leverage every scan. If you'd leverage every scan that's out there, regardless of what pathology it comes from, healthy people with various mental health concerns, different scanners, different countries, anything for that first step. let the model develop, understand sort of the brain grammar, and then use our very precious but small-scale clinical data sets to do the fine-tuning step. I'll skip the slide. Now, of course, brain signals aren't language. So for fMRI, these look like time series. What we were able to do is we got inspired by the field of computational finance. Essentially, market fluctuations, so like stock market, time series have very similar properties to the functional MRI signal. And so we used some of the frameworks that those fields have developed to be able to tokenize or render the brain signal into a sort of language that we could use to train our model. And then for the unsupervised task, step one, we did a combination of three separate objectives. First objective, we gave the model brain scans from the same individual, several scans from the same individual, several scans from other individuals. We let the model figure out which ones are which ones, and it gets sort of the loss function. Essentially, it gets penalized every time it makes a wrong guess. So it's incentivized to make the right guesses. The other task that we thought would be important is to fill in the blanks. We randomly mask a brain region. We let it have access to every other brain region, and then we teach it to guess what the activity would look like in that masked region. And thirdly, temporal prediction. We give it a snapshot of brain activity, and then we have it predict what comes next, like 20 time steps into the future. And what we found is that those models, if you give them enough brain scan, they do a fantastic job. So almost perfect performance on held data when it comes to figuring out which brain scans come from the same individual. So like fingerprint level performance. Very robust performance on like fill in the blanks, as well as the future prediction, as long as it's like within 20 type steps, 20 seconds into the future. So it catches about half the signal. Now, all of that is a means to an end for us. I'm a clinician scientist by nature, interested in clinical questions. And so for me, what was interesting is step two. Now that we've gotten this head start, because we have those foundational, the model knows those foundation principles, how can we teach it something that is clinically relevant? And so we took those small scale but highly detailed data sets that we have. So these consist of imaging plus clinical information. These could be symptoms, behavioral performance on cognitive tasks, treatments, anything. And we feed them together in this like fine-tuning fashion. And what we found was that on benchmarks, this method worked really well, outperforming conventional machine learning methods that do not include this initial step one that is unsupervised. So we did this across a variety of prediction tasks, and it performs robustly on all of them, either comparing favorably or vastly exceeding the benchmark. But a more interesting question is, can these be used to forecast treatment response? So not just decode how someone's feeling right now, but how they might do on a specific medication. And so because of the vast data sets that we have in the center, we've been able to have access to a very good data set, a very large data set by neuroimaging standards. Not just for pre-training, but also for fine-tuning. So in total, 642 individual patients who've completed trials of different types of medications. So 2 SSRI, 1 SNRI, TMS, behavioral therapy, placebo. And we encoded all of that information, as well as how they did 8 weeks later on their symptom assessments. And so we're able to reformulate the question. The most relevant question, in my opinion, in the field is not what's the best drug for depression, because I don't think there's such a thing, but into what's the probability of response given this person's brain scan if I intervene with a specific treatment. And I think that that's a much more tractable question. And so what I have here is just a demo snapshot of what our prototype looks like, which we call neurofoundational models, or affectionately NeuroFOMO. So essentially, it loads the frozen model. doesn't make any changes to the training data at this point, and we're using it in inference mode on an N of 1 basis, meaning after training, we test it on a subject that it hasn't seen in its training data set. And as you can see, it can give you a not just a single probability of whether someone's going to respond or not, but it could do it based on the different treatments that we have in our training data. So for this specific example, you see that per model prediction, say venlafaxine, this person has a higher chance of responding to venlafaxine compared to, let's say, a traditional SRI like escitalopram, and that it's probably worth it to intervene because if we wait, so the placebo combined with care as usual arm was only 21%, had only a 21% response rate prediction. And so this could also tell you, perhaps some people do not require therapies and we just wait. And so it could also give us this information. Now, most importantly, whenever we come up with these models, obviously this is a very early research example. These need to be heavily tested. So everything that I showed you has been tested on several held out subsets of the data that hasn't seen during training, but that's definitely not sufficient. And for like the real test, we need to see how it performs on prospective data. So we freeze the model, we recruit new patients, we let it make its predictions, and then we see how it fares later on. We compare it to those pre-registered predictions. And we have several trials, including ACD, that follow this similar design. And at the same time, we're also working on expanding the menu of therapeutic options that we have. And so we're testing targeted therapies to be able to add these to the training data, including pramipexole reward circuitry and guanfacine for cognitive control, for the cognitive control circuit. So we'll be able to add all of these once we have enough data. And finally, translation. As my colleague Eric, the next speaker, will tell you, we've been making great progress into making a lot of these methods available to patients. So we do offer sort of functional MRI circuit assessments via our precision psychiatry clinic in collaboration with radiology. So we're really excited about the trajectory that this work will take. And with that, I'd like to thank one of our collaborators, most of all our participants and patients who really motivate this work. Thank you all for listening.
All right. Our next speaker is Dr. Eric van Staalduinen. He is a clinical assistant professor of radiology at Stanford University and a board-certified neuroradiologist. He specializes in diagnostic neuroimaging with a research focus that bridges cognitive therapy, clinical neuroscience, and computational modeling. His work integrates advanced imaging and AI, including deep learning tools for stroke detection and predictive modeling of outcomes. He also investigates biomarkers of neurodegeneration, such as olfactory changes in preclinical Alzheimer's and Parkinson's disease, and cerebrospinal fluid imaging anatomy. He contributes to interdisciplinary efforts that use neuroimaging to uncover brain circuit dysfunctions underlying psychiatric illness, and is a key member of Stanford's Neuroimaging and Neurointervention Group. He plays a vital role in collaborative case conferences that bring radiologists and psychiatrists together to advance precision diagnostics in psychiatry. So join me in welcoming.
Good afternoon, everyone. I'd like to start by thanking the organizing committee for inviting me to speak today. I have no disclosures to report. I'd like to share how we're advancing precision mental health with neuroimaging at Stanford. And I'll try to illustrate this with a case-based approach. So we're going to start with a patient in their 60s who was referred to our precision mental health clinic for refractory depression. They endorsed depressed mood, inability to maintain focus on tasks, memory difficulties, brain fog, little motivation, and frequent crying spells. They worry daily about loved ones dying and report various physical complaints too, such as hot and cold sweats, shakiness, rapid heartbeat, lightheadedness, speech difficulties, and even hand cramping. They've previously trialed and failed numerous antidepressant medications. As part of our workup, we often obtain brain imaging with structural and functional MRI. So here we see some coronal T1 weighted MR images of our patient. I've annotated several regions of interest for brain circuitry mapping. You'll see here that we have normal brain volume, we have normal gray-white matter differentiation, we don't see underlying white matter disease, there's no masses or other obvious reason for this patient's symptoms. Overall, an unremarkable and kind of normal brain MRI. And so structural brain abnormalities do occur in patients with depression and anxiety. Some have described increased size of the lateral ventricles and decreased volume of basal ganglia, thalami, hippocampi, and prefrontal and orbital frontal regions of frontal lobes. Some have also described decreased volume in left middle frontal gyrus, which can identify a subset of those patients who will not remit to antidepressant medications. And while these imaging findings are helpful and point to an anatomic association for depression, you can see how challenging it is to actually implement these findings in the clinical setting and use them in a meaningful way. And so structural brain MRI remains largely unrevealing and non-contributory in the clinical setting for those with depression. As this is troublesome and frustrating from a clinical perspective, because while we know something is clearly wrong in the brain, we can't see something that we can target and go after, as we would in other situations, like this patient with a stroke, where there's a very clear lesion, or this patient with a brain tumor. These patients have clear lesions that we can attribute symptoms to and target. Patients with depression and anxiety have relatively normal structural imaging and remain non-lesional from a structural conventional imaging perspective. And this begs the question that we need another tool, something else that can help us treat them and offer them better therapies. And this is where functional brain imaging comes in. So this offers unique insights for understanding the neuroanatomical basis of depression and anxiety and other mental health disorders. We have diffusion tensor imaging, which can evaluate structural connectivity, and functional MRI with resting state and task evoked methods. And these help to evaluate neural circuit architecture with activity and connectivity in ways that you can't otherwise see. And this opens up a whole new world for translating these mechanisms to the clinic for radiologists and psychiatrists as we look to use these to evaluate for this basis of disease. Here we see conventional fMRI and DTI examples. So this is an example of the output that we are used to seeing in the clinic. We often do this for brain mapping, for language lateralization. So on the screen left, you'll see a patient who has left lateralization of language function. And on screen right, you see DTI imaging, where we have the streamlines of eloquent white matter tracks overlaid and adjacent to this very clear brain tumor. And so you're able to see where the problems are. And this is the type of output that we often have. Here's an example of the paradigms we use in order to generate this data for language mapping. The visual response naming paradigm asks the patient to read this prompt and think about what it is. The object naming paradigm asks one to look at this picture and think about what it is and something to do with it. And in this way, they're able to generate where the blood signal is going and identify where the language centers are. And so this is kind of different than in the psychiatric setting and the mapping of brain circuits in the setting of depression. And so one way of processing this data and generating this information is with the Stanford OCD image processing system described by Dr. Leanne Williams. And so it probes 6 unique brain circuits and consists of a 3D high resolution T1 weighted sequence. And we do 2 paradigms or tasks. The facial expressions of emotion task, where we evaluate positive and negative affect circuits, and the go, no go task, where we evaluate the cognitive control circuit. And then measures of default mode, attention, and salient circuits are derived from this task data. Here you see an example of a stimulus for our facial expressions of emotion task. And here we see some of the outputs in the brain circuits evaluated with this type of stimulus. Here you see an example of the go, no go task and the brain processing required to generate this type of information for the cognitive control circuit. Here you have a short table comparing the clinical protocols for our brain mapping. So in those with depression and anxiety, we run these three paradigms, and each one is about 5 minutes. This is in comparison to the language lateralization, where each paradigm is about 4 minutes. So slightly longer, but we are able to integrate this into the clinic and get real-time data. So our patient underwent brain circuit mapping for precision mental health assessment, in addition to a battery of other cognitive tests. Here you see an example of some of the output measures when we do this type of testing. And so we have an overview of each individual brain circuit where the regions of interest are and what those circuits are showing and how they're important. Here we see a summary map of our patients' individual scores, and we see individual scores per circuit, and this gives you an idea of where problems may be. And if you haven't seen these before, that's okay. The scores range from 1 to 10. And a healthy range is considered 3.5 to 7.5. And so if you have scores within that range, they're considered normal or healthy. If you have scores outside of that range, either too high or too low, these are considered abnormal. And these are in comparison to those with depression, anxiety versus healthy volunteers. And so you'll notice that in our subject, we see dysfunction in the salience circuit. We see a slightly decreased brain circuit score. As we probe further into the individual brain circuits, you'll see here we have an example of the default mode, and here we're looking at connectivity throughout this circuit, and you'll see that it is generally falling in the healthy range. Everything is looking good. When you look at the salient circuit, we'll see that things are a little bit on the lower side, with the average score being 3.4, and this was indicated in the overall summary map. When we look at the attention circuit, you'll see that the scores are in general along the low normal range, but there is one area of decreased connectivity between the mesial superior prefrontal cortex and the right lateral prefrontal cortex that is outside the range of normal. When you look at the negative affect circuit in response to a sad stimulus, you'll see that the scores are kind of varied, and the overall average score is within the healthy range, but there is one area of markedly decreased activity in the pregenual anterior cingulate cortex that stands out. When you look at the negative affect circuit in response to conscious and non-conscious threats, you'll see that these scores are generally within the healthy range, and we're not seeing any problems there. And likewise, when you look at the positive affect and cognitive control circuits, we're seeing that scores are again falling in the healthy range. So how do we best interpret this data? So we found that at Stanford, we have developed a collaborative multidisciplinary approach between psychiatry and radiology in order to interpret all of this data. And we call our meetings connectivity conferences, and they're kind of akin to a tumor board. Together, we review all relevant patient data and information, and we generate a personalized assessment and treatment recommendation for them. Together, we look at and review and correlate their self-described symptoms and symptom score reports. Here's an example of some symptom reports that we have. We look at cognitive assessments and various measures of cognitive testing. So this is part of the total brain package where we're looking at different ways of thinking and functioning. We look at prior treatments and treatment failures. We even look at pharmacogenomics and try to probe as to why maybe somebody didn't respond to a treatment, if it was dose related or if that was a factor. And of course, we look at the imaging data, both structural and functional MRI. And so our patient reported moderate symptoms of depression, anxiety, and trauma-related experiences with overall low satisfaction of life. And the most severe and frequent symptoms were fatigue, cognitive problems, and anxious ruminations. Here we see an example of their reported symptoms. They also reported these episodic neurologic symptoms, including hot and cold sweats, shakiness, rapid heartbeat, lightheadedness, speech difficulties, and hand cramping. Here we see an example of the symptoms that they reported. And so in terms of interpreting this data, the structural imaging was helpful. It was negative for signs of neurodegeneration, negative for signs of small vessel disease or demyelinating process or mass. That helped us in this case because there were neurologic symptoms at play. The fMRI revealed salient circuit hypoconnectivity, some attention circuit hypoconnectivity, and low activity in the pregenual anterior cingulate region. It also demonstrated healthy activity in the default mode, positive affect, and cognitive control circuits. And so we concluded that this patient had salience and attention circuit dysfunction characterized by hypoconnectivity. And we also suspected that they had a functional neurological disorder to account for some of their symptoms. We then recommended a trial of atomoxetine as it can increase attention circuit connectivity and has been shown to improve attention in adults with ADHD. And it can also target ruminative worries and physical symptoms of anxiety. We also considered bupropion as a backup in case of treatment failure, as it can target fatigue and attention. I'll briefly discuss a companion case. And this is a patient in their 20s with moderate to severe symptoms of depression and anxiety. These are most notable for anxious ruminations, suicidal thoughts, anhedonia, and multiple failed antidepressant medications. Here we have a screenshot of their brain circuit scores for the default mode and frontoparietal attention networks. And you'll notice that these are characterized by increased connectivity throughout the default mode diffusely and increased connectivity throughout the frontoparietal attention network in the mesial superior prefrontal cortex and the left lateral prefrontal cortex. we concluded that they were characterized by default mode network and attention circuit dysfunction with hyperconnectivity, and we recommended TMS for this patient. I won't discuss TMS any further, as Dr. Nolan Williams, who's an expert in the field, will be talking about it next, and so you'll look forward to hearing that. I'll close by highlighting future directions and opportunities for precision mental health. First, I hope I've illustrated for you a clinical pathway forward for precision mental health using neuroimaging at the individual level. And we're optimistic that this approach can save patients from prolonged suffering and cost owing to medication trial and error periods and help to guide them to directed therapy the first time. Second, we're really excited about this opportunity between radiology and psychiatry as we look to transform our understanding of and approach to mental health with the chance to shift the paradigm of classifying these as collections of symptoms to individualized measures of brain circuit dysfunction. And so as a neuroradiologist, I see a ton of opportunity and potential here for education, collaboration, and the development of future biomarkers to help guide therapy for these patients. This won't happen without continued support of the healthcare system. And if we do go forward with relying more on neuroimaging for these assessments, we're going to need to refine clinical workflows, improve access to MRI, and greatly educate the public, the patients, the clinicians, and everyone as to what this means. And so in closing, I hope that our model of practice can serve as an example to others as we help to usher in this era of precision mental health. Thank you.
All right. The last speaker in this panel is Dr. Nolan Williams. He is a professor of psychiatry and behavioral sciences here at Stanford and director of the Stanford Brain Stimulation Lab. He's a triple board certified neuropsychiatrist, and he develops neuromodulation and psychedelic-based treatments for mood disorders, OCD, and related conditions. His team pioneered Stanford Accelerated Intelligent Neuromodulation Therapy, or SAINT for short, the first non-invasive rapid-acting treatment for depression to receive FDA clearance and Medicare reimbursement. Dr. Williams uses neuroimaging-guided methods to precisely target and predict treatment response. He also leads clinical trials exploring psychedelic compounds like ibogaine. His research has been recognized with awards from NIMH, Wellcome Leap, One Mind Institute, and the Brain and Behavior Research Foundation. A formal dual neurology and psychiatry resident at MUSC, Dr. Williams has been featured in Scientific American, New York Times, The Washington Post, CBS Sunday Morning, and Today, highlighting his impact on neuroscience and mental health care. Please join me in welcoming Dr. Williams.
How's everybody doing? See ya. All right. My disclosures. All right, so we'll talk through the neuromodulation half of the work that we do because of the short period of time. Yeah, so I focused a lot of my my time thinking about depression because it's the most disabling condition worldwide, and it's comorbid with everything, right? And it makes everything worse that it's comorbid with. So if you have a heart attack and you're depressed, your mortality and morbidity go up. If you have sepsis and you're depressed, you do worse. So depression is its presence makes everything worse. And it's a risk factor for things. And so if we can solve that problem, maybe we can solve other risks. And more specifically, we got zoomed into this idea that as a generality, the treatments that we use aren't aligned with the acuity of the problem, right? If I go into the hospital, I'm having chest pain, there's a bunch of tests and treatments for me, and they happen really quickly. Within a couple of days, and I get it sorted out if it's sort outable, right? In the case of depression, you go in, you spend a very long time in the hospital sometimes, and the treatments that we give are no different than the ones that you would get in the outpatient setting. And the real problem with that is that the suicide risk for folks triples at discharge. You know, it's the second highest risk factor for suicide, the first being a previous suicide attempt. So it's the only really modifiable risk factor. And it makes no sense, right? I shouldn't go out of the hospital after I have a heart attack and have a tripling of my risk of having my second heart attack, right? That doesn't sound so good. So how do we solve kind of that problem, and how do we do it in a week? And so we really started to think a lot about that, right? TMS as a technology has been around since the mid 80s as a treatment, experimental therapeutic since the mid 90s, as an approved treatment by the FDA for depression a little bit before the 2010s, 2008, 2009. And, you know, people looked at it and thought, yeah, this works pretty well, but it's slow and it doesn't work in, more than half of people. It doesn't remit more than half of people. And so one way of looking at that is kind of looking at it from this kind of way of thinking about a treatment like a pill, right? And that's just what it is. The other way of thinking about a treatment, and this is kind of the engineering way of thinking about a treatment, is to think about it more like a car, right? The Model T, or like a scalpel. The Model T worked, but none of you are driving that, right? And engineering advancements over time have made that technology better. The first surgery using a scalpel probably didn't go that well. Maybe it went okay. It certainly doesn't go, it didn't go as well as the same surgery performed here at Stanford today, right? Because we've developed an understanding of that tool. And so I say all that to say that I want you to think about TMS like that. TMS is a device that induces a current in underlying brain circuits by using a high-powered magnet, pulsing that magnet, and using Faraday's law to induce current generation in electrically conducting substances. You do this over sand at the beach, it doesn't do anything. You do it over brain circuits, and you do it in the right way, you can turn them on, and you can actually modify them. And so that's what TMS does. The first kind of set of TMS experiments were, in retrospect, probably overly cautious and under precise, and were able to modify some brain circuitry in some people and have some results. And then there was a natural kind of evolution of the technology to improve it, but it was more of an evolution than a revolution, right? To where the 1995 kind of approach, generated a few people in response remission. And then by 2008, 2009, you get this kind of treatment protocol that doesn't really solve the clinical problem that I just spoke about, but can get people well in the kind of normal schedule of about 6 weeks. Since then, there's been an advancement on how the stimulation signals in the brain. The first kind of way of doing it was derived from just like, kind of parametric studies where you just vary the frequency, but we didn't know that much. This kind of second generation of parameters was derived from recording in mammalian brain tissue, mammalian hippocampus, and then playing it back through the TMS coil into the brain, and then activating the brain in a similar sort of way to the way that that the brain signals itself, right? And so that's called theta burst. It uses signals that are similar to the way that the brain signals itself, and by doing that, it produces a kind of a step function of efficiency. So instead of the stimulation taking almost an hour, it can take a couple of minutes and produce the same changes in excitability. And so this is the sort of readout that we use. So we use this motor evoked potential readout to understand how the technology is modifying the cortical excitability. We do this over the motor system because it's easily measurable, and intermittent theta burst produces excitation. And so we know that if you then take that excitatory stimulation approach and you play it into prefrontal circuitry, you can actually produce a similar effect to the old way of doing it, right? And so this is Jonathan Downer and Jeff Daskalakis's work showing that if you play that same older kind of rhythm that was originally approved against the hippocampal rhythm, you can get a similar sort of clinical improvement, right? And so what we wanted to do is we wanted to try to re-engineer the approach such that you're able to solve that clinical problem, right? And that clinical problem is, how do you bake the cake faster? How do you make the stimulation work over a shorter period of time for more people? And so the first set of questions is around, well, what's the kind of fundamental unit? And in this case, the fundamental unit is that theta burst approach I just described to you, but there's a catch, right? There's kind of this dose intensity sweet spot that's been kind of identified across a couple of different studies where you need submotor threshold dose, so kind of actually lower intensity and a certain amount of pulses, in this case 1800. And that's kind of the unit, if you will. Is there a better one with more experimentation? I'm sure there is, but for pragmatic purposes, we landed on that. As actually, this was a paper published in Brain about a decade ago, showing that sort of 1800 pulse dose and then intensity, that submotor threshold, is effective even when it's applied once a day. And then the second thing, right, is we know what the unit is, or the amount of stimulation. And then the second thing we wanted to kind of know was, once you had that, what is the repetition rate, right? How quickly can you stimulate again such that you're able to get the person's brain to receive the first stimulation and kind of get it to a place where when you stimulate again, it will optimally interact. What I just said may have gone, over you, or you won't process that in your normal life of what does that really mean? But I'll give it to you in a different way. How many of you have used note cards to study? Right? How many of you wrote one note card down and looked at it 50 times and then never looked at it again? Maybe one. All right. How many of you wrote out 60 note cards and looked at each one of them for a minute and then got back to the first note card about an hour later? The ones of you, all right. Are there other ways? I'd be interested. There's a couple of you in the audience that did like the 500 note cards and never got back, right? I know those ones. So most people actually intuitively know this principle of spaced learning. And the reason why you know is because this is kind of optimally how people will learn, right? And so that idea of writing out 60 note cards and getting back to the original note card has been observed over and over again in psychological experiments and these basic science experiments where you can actually stimulate and measure dendritic spine enlargement and then stimulate again at varying intercession intervals. You can see the same principle played out again, whether you do it at the hippocampal slice level or you do it at the psychological student experiment level. The story is the same story, which is it's about an hour. You need about an hour of exposure to kind of optimally interact. And there have been a number of accelerated theta burst studies where they didn't do this and they didn't get any clinical benefit. And so that's kind of principle one, it's the how. The second principle that we've thought a lot about is the how much, right? And so TMS was dramatically underdosed with its original dosages. Seroquel was dramatically underdosed with its original dosages for schizophrenia, right? We were giving people 100, 200 milligrams of Seroquel when it first came out. There's a lot of examples in medicine where we were cautious and we gave too little and then we say, oh, maybe this doesn't work that well. But then if you keep going, you take, in this case, all the people that didn't really do that well with conventionally applied TMS, and you just simply give them more weeks of stimulation, you convert 2/3 of them over to be responders. And so this idea of not just how, but also how much do you need to put into the system to get the person to a place where where they're able to respond. And so this is the way we were thinking about it, this idea of applying, again, this kind of hippocampally derived stimulation approach. And we're able to do that over a period of time of 2 seconds with an 8-second intertrain interval that produces excitations we talked about earlier. And then we give 9 minutes of that in the way that we're applying this accelerated approach with a 50-minute intersession interval to recapitulate that learning principle. And so by doing that, we're able to actually apply a lot of stimulation over a short period of time. Right? We're actually able to apply an entire 6-week course over a single day of the originally approved theta burst stimulation. And that allows for us to get people well in a short period of time. I've had patients that have been really in severe shape to totally well after 1 day, but the average is about 2.6 days. And it's just really reorganizing the stimulation in time. Right. And then giving the amount of dose that you need with the reorganization in time. Does that make sense? So then the third principle is this principle of where. And there's kind of the macro where within the named brain region, right? And then the micro where within, which named brain region, and then the micro where within the named brain region. And so left dorsolateral prefrontal was really the area that's been studied the most for stimulation. And then we really thought a lot about where within the left dorsolateral. It's like a 5 or 6 centimeter spread. The old way of thinking about TMS is that it's got this broad induced E field, but the newer kind of experiments in macaques show us that actually the induced spiking is really quite narrow. And so, you have sub-centimeter induced activity. And so if you put kind of a circle that has a diameter of about 1 centimeter within a larger circle of a 5 or 6 centimeter spread, there's a lot of stimulation targets within that bigger brain region, right? So not everywhere is going to be the same. This work was done and inspired what we why we started doing targeting by Mike Fox's group. It's one of the most replicated findings in neuroimaging and psychiatry. And it's basically if you use normal targeting, the kind of skull-based targeting, the linear distance to the ideal target, the shorter that is, the better people do. There's a study that was just finished out of Harvard where they did connectivity targeting versus the standard skull-based targeting, and they had a Cohen's d of 0.92 of connectivity targeting on the clinical effect, just a massive effect. And so what do? We're looking for the where within the brain network, where within the dorsolateral kind of optimally interacts with the subgenual anterior cingulate, and that's what we're trying to target. We use hierarchical clustering to cluster similarly behaving voxels that allow for us to have kind of a cluster to deal with within the dorsolateral, and then we ask the question of what its connectivity is to the subgenual. And then when we do that, we're able to then produce an individualized brain target that's capable of interacting with the subgenual cingulate in an ideal way. And that functional position is different in everybody, and the structural position is different in everybody, and the skull spot is different in everybody. And so this idea that you can somehow derive a skull spot that's going to tell you where to go doesn't work, as I'm sure neuroradiology friends will attest. So this is the stimulation approach. This is just another way of thinking about it. This is our first trial. People were 50% of them were on disability for depression, average length of current illness 9 years, average length of lifetime illness about 25 years. Cohen's d effect size is above 1 across all of that. I'm going to skip through this because I'm out of time. I'll just show you. And this is this is actually accepted by World Psychiatry and published in a month or two. This is our replication trial funded by NIMH and very similar effects to the original trial. So really quite excited about that. Yeah, and through this is all my folks, and wouldn't be here without all their support and the support of our funders. Thank you very much.
So we're just going to have everybody come up. Yeah. Save you some time walking. All right, so we going to have some announcements afterwards. We have time for 3 questions. Go ahead and line up on the back, and you're welcome to or shout it out.
Hi.
Mayor, go ahead.
So I'm a parent here in Palo Alto. My name's Mayor Lucas. I lost my son to suicide 8 years ago, and we've had 3 suicides here in Palo Alto of youth in the last 6 months. So as many of you know, I'm on a quest. So question number 1 is, I know a lot of this data sets and everything like that is focused on adults, and I understand why. But are you looking at going downhill? You know, if you look at fMRIs of youth, is there a way of like predicting that forward? Because I would have loved that to have happened. So that's kind of question number 1. And then question number 2, but I don't want to hog it, be quick answers. But I also recently got past cancer, and that's like, I'll call it situational depression. And I was wondering, are you looking at some of this and working it into, like, I don't know, my chemotherapy treatment, for example? So sorry, they're widely divergent, and pick one or both.
Thank you so much. Who would like to go?
Maybe I could go first. There's no reason why the work cannot be extended to younger populations. Because I'm interested in treatment specifically, with medication treatments, there's like a relatively smaller repertoire of potential options in younger patients. And so for practical reasons, I decided to focus on adults, but there's no reason it cannot be extended to the population below 18.
Thank you.
Sorry, Mayor, I just want to say thank you so much for sharing that. And you and I really, are allied in wanting to do more for our teens, especially in this area. And I just want to commend you and keep asking those great questions. Keep insisting that we push the science border. We're a long ways to go to help our kids.
Hi, I'm Kaya. I'm in 7th grade. I'm really interested in neuroscience. Thank you guys again so much for giving these talks. My question has to do with neuroimaging and how it could possibly help with diagnoses and learning differences. As a student with OCD, I know it can be really hard sometimes to know what's going on in my brain, and I know other people go through the same challenges. I'm wondering if there's possibly a way to use neuroimaging to give more personalized diagnoses to people so they can more understand what they can do to help themselves and lower their anxiety levels. And if possible, if you see a future in making neuroimaging more accessible to the general population.
Kaya, thank you so much for your wonderful question. You are the future. Thank you so much. Okay, right? Amazing question. We're going to have Eric field that one for you.
Yes, thank you for your question. That's an excellent question. I think we can expand our neuroimaging applications beyond depression and anxiety to OCD. This work just has not been done yet from my understanding, but I think there's potential for that. In terms of targeting patients with those types of disorders, that is happening. So there's studies that are happening here at Stanford and elsewhere using neuroimaging biomarkers to improve the accuracy and response rates to various treatments. A few of them are neuromodulation based, and the identification of the optimal target is what's being discussed. And whether we look at specific anatomic regions, which is the more classical approach, or maybe targeting various networks or pathways. I opted not to go into that with our talk as we focused on depression. It's more clinically kind of a bigger player at this point, but OCD is certainly up there and coming. So I think that there will be more targeted treatments going forward, and I hope that that offers some hope.
Yeah, thank you, Kai. And before we go to our next question, I just want to shout out Lawrence Fung, who has a Stanford neurodiversity program and summer camp, and my son went to it, and it was just really wonderful. So thank you.
Hi, my name is Adam. I'm an instructor in psychiatry. I have a question about the individual level fMRI circuit scores, essentially. I've been working in fMRI for a long time, and it's really exciting to see this clinical translation. You know, people often wondered whether it would happen, and most of the fretting has been about kind of low effect sizes and test-retest reliability. What do you think are kind of the main methodological leaps that have happened to allow us to get to these kind of individual level scores? And do you have any concerns about reliability at the individual level?
Yeah, thank you. That's, I think, a fantastic question. I think why we've been able to translate it here is just because of some of the experts that we have, the experience they have, the trials that they've used, and our willingness to incorporate it as a component of the treatment plan and not necessarily be the be all and end all of it. And so we're correlating those measures with other measures of cognitive function and testing, and even looking to integrate, like Teddy was discussing, some maybe AI perspectives to it. I think the bar is kind of low in the sense that, you know, trial and error is kind of the status quo. And if anything, this offers a new target or a new perspective for patients to try. And so often people are coming to us with kind of like end stage, failed everything, and they're looking for an answer. And sometimes we're able to identify something that hasn't been seen yet or hasn't been tried yet, and we have data to support it. So
that's great work. Thank you.
Nolan, do you want to have anybody else have any thoughts before we close out?
Yeah, I mean, I could answer the second comment that was brought up about cancer and treating depression with comorbid medical conditions. I think it was a good question. Yeah, I mean, you know, I brought that up earlier, right? Which is depression makes everything, you know, worse, both from an experiential standpoint. So like comorbid depression in a chronic pain patient makes pain sensation actually more painful, right? So it makes the condition subjectively worse. And then it also makes the risk higher. You have depression in a person that's having a heart attack, their chances of dying from the heart attack or having a worse heart attack are higher than somebody that's not depressed, right? And if you think about that, if depression really is so pervasive and it's so problematic for other conditions, it seems to me like from a healthcare spending standpoint that we would be way more focused on dealing with it from the standpoint of how do we kind of actually risk mitigate lots of different problems, and how do we actually make lots of different medical conditions better. And so I think that perspective hopefully will, you know, there's a bunch of efforts in play right now to try to show that. Our healthcare system is like financially not set up that well to show that, and we're, you know, surprise, surprise. But I do think that if you can show that, and you show particularly if you can show insurance companies, hey, look, we treat this person's comorbid depression and they get out of the hospital, you know, get out of the hospital a day or two earlier. We know that with like total knee replacements, people get out of the hospital a day or two earlier if they don't have depression. You show that kind of stuff, then maybe you're able to make a difference in, you know, in that experience, and, you know, kind of recognize it as a problematic comorbidity. So.
Wonderful. Nolan, Eric, Teddy, thank you so much. Join me in